Alok sir, are you there?
Yes, I am there. Yes, we can start.
Okay. Okay. Uh, Bobin sir is in a meeting, I think, so we can start now. So today's PG class 32nd section on ISMBO Ampok PG class session. Today we have Dr. Sriram as presenter. He is a second year ERNB medical oncology resident from MVI Cancer Center. And we have two eminent teachers. One is Dr. Anup. Anup sir is professor at RCC Trivandrum. Along with that, Dr. Alok Goyal sir. He is from TMH Mohali. Handed over to our teachers. Can start the presentation. Anup sir.
Yeah, please.
Good evening, sir.
Yeah.
I'll be presenting a case on lung cancer.
Yeah. Yeah, please start.
Yes, sir. My patient, Mr. Alavi, who's a 68-year-old male, who's a farmer by occupation from Malappuram in Kerala, presents to the OPD with chief complaints of cough with expectoration for the past 3 months, and shortness of breath for the past 3 months. History of present illness. The patient was apparently normal 3 months ago. Patient then developed cough with expectoration, which was of insidious onset. Cough was aggravated in the morning and after meals and relieved on taking antitussives. It was associated with moderate amounts of sputum production. Sputum was white in color, serous in nature, non-foul smelling, more in the early morning. There was no history of blood in the sputum. Patient also complains of breathlessness since 3 months. Initially, he had breathlessness only when he did strenuous work. However, over a period of time, it increased, and now his breathlessness is as worse that he gets breathless when he walks a few yards only. Patient did not complain of any chest pain. There's no history of fever, orthopnea, nocturnal dyspnea, no history of weight loss or loss of appetite. No history of engorgement of veins, neck veins. No history of bone pains. No history of pain abdomen or abdominal distension. There's no history of any other swellings in the body and no history of headache. Past history, patient has had frequent episodes of breathlessness and was diagnosed with chronic bronchitis in the past and has had previous admissions 3 years ago for the same at Calicut Medical College. Patient is also a known case of hypertension and CAD and is on treatment for the same at Calicut Medical College. There's no history of any other systemic illness. There's no history of any previous surgeries. Personal history, patient was a chronic smoker since 20 years. He used to smoke 2 packs of cigarettes per day. The pack years is 40. Patient is a non-alcoholic. He consumes a mixed diet. He has normal sleep pattern and normal bowel and bladder habits. Coming to family history, there's no history of any similar illness in the family. There's no history of any known cancers in the family. So coming to the summary, a 68-year-old male who's a chronic smoker with previous history of chronic bronchitis, CAD and hypertension. He now presents with a history of cough with expectoration and breathlessness since 3 months.
Okay. So from the summary, so what is your diagnosis, or you have any differential diagnosis from your
Sir, I have differential diagnosis. Patient actually, sir, he's already having history of chronic bronchitis. So that could be one cause. Secondly, this chronic bronchitis patients, they have pooling of secretion, so some infection could be there. In India, tuberculosis or any other lung infection, that is one of the differential. And also, sir, due to the chronicity of the history, around 3 months duration, I would like to keep a lung malignancy also as a differential.
So why you say that it is your second differential diagnosis a lung malignancy? Because from the history, it's more of an infection, nothing to suggest a malignant lesion or a malignancy from the same summary. Only because of a 3 months history, you put it as a malignancy in this patient.
So differentials, like to work up the patient further.
Okay. This patient is more of a chronic smoker also. That is
Yes, sir.
also an
Chronic-
important point in this patient,
Yes, sir. Chronic
rather
smoker.
than chronic bronchitis. Okay.
Farmer by
So
occupation.
rather than infection, is a chronic smoker and all elderly patient, older age and chronic smoking. And
So, is there any history of weight loss, any history of fever? Had you mentioned negative history? Was there any history of fever or weight loss?
No, sir. No, sir. No fever and no weight loss.
Very, very unlikely a patient of
Yes,
chronic
sir.
bronchitis having 3 months of no weight loss, no fever. Uh, so it's very difficult. Even if in pregnancies, if you think of it, there will be 3 months of fever. Will have some nights of fever, some fever during exertions, or some weight loss. So without weight loss, to
Yes.
put a
Yes, sir.
pregnancy in, this will be very, very unusual.
yeah,
Yes, sir. I asked in the history, but patient did not give
That's
any.
fine. I'm saying with the history, I will not keep pregnancy in top three. That is what I'm
Yeah.
saying.
Yeah.
Yes.
Could be due to a bronchitis. We can say it is a infection.
Acute exacerbation of bronchitis, which is going
Yeah.
on with converting to COPD, patient having bronchitis, having cough, but no fever. It's not fitting into anything typical. It's looking like chronic bronchitis with exacerbated in between, and it is going on because of some bronchiectasis. Now, patient developing increase in breathlessness. That is the most probable, which will come out of the history.
Yes.
Suppose if you have a fever, recurrent pneumonia, that is a strong point to say that it could be underlying malignancy in this patient.
Yes.
Recurrent pneumonia in an elderly man,
Yes.
rigorously treated with antibiotics, still having a recurrent pneumonia, that could be due to underlying malignancy.
And why Dr. Anup is saying that this could be a sign of malignancy? What will be a pathogenesis of malignancy in this case? How will infections occur in malignancy, this type of infection?
Sir, there could be, sir, infections. They cause actually chronic lung injury, due to which some inflammatory means cytokines like NF kappa beta can be released and TNF alpha, which can further
No,
progress.
I'm saying why a history of chronic like recurrent infection can, in what conditions lung cancer, a chronic infection can occur, recurrent infection can occur.
Uh,
Mostly when there is a bronchial obstruction causing atelectasis and some pooling of secretions.
Cooling of
In
secretions.
that time, the patient will present with breathlessness and recurrent infection because of pooling of secretions in that case. Yeah.
Yes.
And how do you investigate the thing when you said that a cough increases with meal? What will be a DDA in that case if you are saying that cough increases with meal?
Uh, of increasing with after meal.
That is what your history is. Ki cough increase is more in morning and increases with meal.
Yes, sir.
Morning is fine because asthma, bronchitis increase, but you have said that cough increases with meal. How will you interpret that thing? What could be the possibilities of cough increasing with meal?
Probably some likely fistula or
So yes,
GER.
that things need to be investigated. If that history is there, why cough is increasing with meal, and so that need to be kept in mind. Yeah.
So go ahead with the clinical.
Yeah.
So coming to the examination part, patient is conscious, oriented to time, place, and person. He is afebrile. His ECOG PS1. He's thin built and well nourished. Vitals. His heart rate was 80 beats per minute. Respiratory rate was 16 per minute. The blood pressure was 140 by 90 mm per mercury, and SpO2 was 95% in room air. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Coming to systemic examination, I would like to examine the respiratory system first. So coming to inspection, I'd like to begin with the examination of the upper respiratory tract and the oral cavity. So mouth opening is adequate. There is poor oral hygiene. Multiple tobacco stained teeth are present. There is no dental caries or oral thrush. Coming to nasal cavity, there is no DNS, there is no polyps, no other lesions are identified. Inspection of the trachea appears to be in the midline. Shape and symmetry of the chest wall. The chest is bilaterally symmetrical. it is elliptical in shape. Both sides move equally with respiration. The type of breathing is abdominothoracic. There is accessory muscle use is present. There is hollowing of the supraclavicular fossa. There is intercostal indrawing. Mild kyphoscoliosis is present. Skin over the chest is normal. There were no scars, sinuses, or any dilated veins. Apex beat appears to be in the fifth intercostal space. Coming to palpation, tracheal position was confirmed to be in the midline on palpation. Coming to the apex beat, it is in the left fifth intercostal space, that is 1.5 centimeter away from the midclavicular line. The chest expansion was palpated. It was found to be 4 centimeter. Anterior and posterior thoracic measurements are actually normal. Mild tenderness is present over the right chest wall. There is no subcutaneous emphysema. Vocal fremitus, it's equally appreciated on both sides. Percussion, bilaterally, normal resonant nodes were appreciated in all lung fields. No significant findings are there. Auscultation, bilateral normal vesicular breath sounds were present. There was diffuse crepitations present on both sides of the lung. There were no other added sounds. Other systems, the CVS, parabdomen, and CNS all were under markup.
Can you please summarize your positive examination findings?
Sir, a 68-year-old thin-built patient. He's means on inspection had
A summary of your positive
the positive, sir,
examination findings.
signs of could find that there was actually, sir, accessory muscle use.
So you said the respiratory rate is 16. It's very unlikely that person who is not breathless using accessory muscle respiration has a respiratory rate of 16 only. Isn't it unlikely? Well, if he's using accessory muscle,
usually
there will be some tachypnea which will be there. 16 pulse respiratory rate will be too normal for person who is using accessory muscle respiration, because he's working hard to take the oxygen in. The respiratory rate automatically increases. So the examination findings are not collaborating each other. And how will you interpret bilateral diffuse crepitations? What type of creps are there? Fine, coarse, velcro type. What type of creps were there?
Sir, actually, sir, it was coarse crepitations. And
diffuse means what areas? It is in both up to from infrascapular to suprascapular area, or all areas of the lung are involved? What do you mean by diffuse coarse crepitation or examination?
Sir, mostly bilaterally it was there, sir. The suprascapular and infrascapular both.
Well, you're saying both the lungs bilaterally from up to down, there were creps.
Creps are there, yes, sir.
Okay.
So, what is your after your clinical examination, what is your diagnosis in this patient? So you have the history, you have the clinical examination findings. So what is your diagnosis in this patient?
Sir, again, sir, I would like to keep chronic bronchitis as a diagnosis. Then means some acute exacerbation of chronic bronchitis. Then second diagnosis will again I'll work up for infection. Then third I'll keep as malignancies.
So why on examination you are saying chronic bronchitis? What will be there in chronic bronchitis on your auscultation?
Sir, usually these will be there.
Your bronchi should be there, but you only have diffuse capitation. Why are you keeping chronic bronchitis at your first diagnosis?
Some suprarenal infection also is a possibility.
So co-scripts, what are DDs of co-scripts which are bilaterally diffuse?
Sir, bilaterally diffuse co-script. Sir,
that's the only positive finding, no? Yeah.
Yes, sir. Sir, pneumonitis.
Bilateral lung pneumonitis, which is including all the lobes of the lung.
Interstitial lung disease could be there. Bronchitis.
What type of creps are there in interstitial lung disease?
You expect acute interstitial pneumonitis or some form of chronic?
Sir, could be like 3-month history. So
what do you expect from a 3 months history of pneumonitis? without any positive history. Is the patient had any COVID?
Sir,
History of COVID? Any history of COVID or infections?
COVID, no, sir, no, sir, no, sir.
No.
So the only thing which you can explain by this thing is very, very difficult for the patient you explained with 16 respiratory rate, having dyspneic at rest. मतलब you said कि he, one history you said कि he get dyspneic on movement, but as per your examination he was dyspneic on rest, but he was comfortable with bilateral diffuse cough, no fever.
No
It's
fever.
difficult to explain all the things, so it look like a atypical infection which is on the lung, but patient is too stable for that to have atypical infection, a viral or a atypical infection, both the lungs causing this type of diffuse co-scripts, because co-scripts mostly are seen in infection or post bronchiectasis, which is there.
Yes, sir.
Okay.
Okay, Sriram.
Yes,
So
sir.
you have a patient with the possibility of a chronic bronchitis with repeated exacerbations. So
Yes.
how you are
Uh,
going to manage? How you are going to manage this patient and investigate this patient?
Sir, first of all, he gives symptomatically he's having crepitation, so I would like to first stabilize him, and then actually, sir, investigate further with the complete blood count, which is like, and along with that, I will send a renal function and a liver function test also. And sir, I will then to look for the disease status. Actually, I will prefer a CECT of the thorax. Since sir,
So
I'm
have you gone for an basic examination, basic first line
X-rays,
investigation in a patient? Yeah,
first X-ray, sir.
chest X-ray you have done this patient. So what is the findings of chest X-ray in this patient?
Sir, this patient actually, sir, he came to us with a CT scan only, sir, directly. He was
Okay.
worked up by
So
pulmonologist.
you would like to even you have a CT,
Yes.
still you want to take a chest X-ray in this patient?
No, sir. CT is sufficient.
Sufficient. You are not convinced with the X-rays.
And you said that he has tenderness in some part of chest wall. How do you explain
Right
that thing
chest.
in this patient?
Sir?
You said in examination he has tenderness.
Yes, sir. Tenderness
Some
on the
part of
right chest wall.
How will you explain that thing?
Sir, pleural involvement or bone. Any
What type of pain will have in pleural involvement? There will be tenderness or
actually,
pleural
no,
pain?
sir, no, sir. Patient will complain of pain while inspiration.
So you have a CT in this patient. What is the CT findings in this patient?
Sir, this patient was worked up by a pulmonologist outside, and he came with a CT which suggests a heterogeneous soft tissue mass-like lesion involving the right hilar and perihilar region of the upper lobe of lung. Along with that, there was significant narrowing of the right upper lobe with the pulmonary artery and pulmonary vein involvement. There was patchy consolidations with adjacent ground glassing opacities involving the right middle lobe and the right lower lobe. And there was multiple enlarged necrotic nodes in the right paratracheal, right hilar regions, the largest measuring around 18 mm. The size of the lesion, sir, was actually around 7.1 centimeter in the largest dimension.
Do you have the films of CT? You have uploaded that thing?
Films are outside films, sir. Don't have the film.
Okay. But always try to read the films also rather than just relying on the report when you see the patient.
Yes. This
Okay.
patient
From the
actually, sir, was worked up outside and he came to us.
yeah, from the CT, what is your staging?
Sir, size-wise, actually, it is 7.1 centimeter. So it is a T4 lesion. And there is actually, sir, mediastinal nodes are there. T4N2, sir. And
Okay.
metastatic, I will, for
What
M
about metastatic?
sir, M status, I will
Other
look
than
at.
CT thorax.
Yes,
What
only
about
CT.
CT abdomen?
Sir, after he came here, actually, we did a PET scan, sir.
So what is the PET finding?
One second. Yes, sir. PET finding was, sir, FDJ avid heterogeneously enhancing soft tissue lesion in the right hilar region, encasing the right middle lobe, causing distal collapse and consolidatory changes in the right middle lobe, sir. It was encasing the right lower lobe bronchus, right pulmonary artery, right upper lobe, branch of pulmonary vein, and extending into the adjacent lung parenchyma. There were FDJ avid prevascular, right paratracheal, pretracheal, and subcarinal nodes were there, and right hilar nodes are also there, sir. And there was additionally FDJ avid ground glass opacity that was seen in the right lower lobe also, which was could be disease involvement. It was commented. There's no evidence of any hypermetabolism elsewhere.
So what about MRI? Will you go for MRI in this patient? Suppose you get a staging
Sir,
like
yes, sir. I like to do an MRI because it's a T4 N2 disease. So above stage 2B, I will always go for. It's a stage 3B. So above stage 2B, I will always go for an MRI brain also.
for all patients with the locally advanced lung cancer.
Yes, sir.
So
What percentage of patient do you expect in this stage 3 to have brain mets if you do a MRI?
Sir, around 3 to 5.
So for 3 to 5, you will get MRI in every patient.
Sir, means occult brain mets are common. So suppose
So
then
how much percentage? That is what I'm saying. For 3 to 5, you will do MRI in 100 patients to pick up 3 patients of. It's higher. It will be a range of 10 to 15 to 17, 10 to 15% somewhere around it, and in stage 3. So therefore, we do it routinely so that we can see whether to treat the patient as a curative intent or not.
yes,
so have you done an MRI in this patient?
sir, yes, sir.
Yeah. What was that?
Sir, MRI did not show any SOL or bleed. No dural lesions were seen. Only age-related cerebral volume loss was.
Okay. So what next investigation will you suggest in this patient? You have MRI, which is normal. PET
Yes.
CT showing a T4N2 disease, M0. So how will you work up this
I would
patient?
like to confirm the diagnosis, first of all, histological type. So, being a hilar lesion, I would take the opinion of a pulmonologist for bronchoscopic biopsy.
Bronchoscopic biopsy. Okay.
So bronchoscopy से करेंगे तो mostly you get a FNAB and FNAC, you get a little amount of tissue. Will you get sufficient amount of tissue through FNAB to do molecular and all those things?
Generally, first, sir, if it's less, then we'll prefer.
Okay, that's fine. I'm just asking how much percentage patient, how much tissue will get through uh, a bronchoscopy guided biopsy, and most of the time is it sufficient to do molecular testing in these patients because that is important.
Yes, sir.
Okay,
So
that's fine. Yeah.
what was the bronchoscopic biopsy findings and what was the pathology in this patient?
Sir, bronchoscopy findings were actually initially, sir, cytology scrapings were there, which was
Please go to
shown.
last bronchoscopy findings. That was which was showing, yeah.
Sir, it suggested an extrinsic compression with the mucosal irregularities.
Okay, so there was
Okay.
mass is not seen internally. Okay,
Intrabronchial lesion was not there.
okay,
Then
okay. So
how,
what was taken here?
yeah, how did you proceed in this patient?
Sir, so we did a cytological scrapings as well as a biopsy. It came out as a small cell carcinoma.
Small cell carcinoma. Okay.
Okay. So why you're saying small cell carcinoma, what ISC markers will help you in finding small cell carcinoma from adenocarcinoma?
Sir, basically it will be positive for synaptophysin, chromogranin, CD56 also, TTF1 also.
How much percentage of small cell carcinoma will have TTF1 positivity?
Uh, 60%.
So most of the 70% will have TTF1 positivity. So that should not be confused with adenocarcinoma. No? Matlab, we need to, in scammer, if it is scammer, then we need to see whether there is some adenocarcinoma component in it or not. So if a squamous cancer has TTF1 component, we need to see that it's adenosquamous. But in
Yes.
small cell carcinoma, TTF1 can be a part of small cell, and we don't need to work up further for adenocarcinoma. That's the point I was just want to make.
Yes.
Okay, so small
What is
cell
the difference between large cell neuroendocrine carcinoma versus small cell carcinoma?
Sir, small cell carcinoma, large cell neuroendocrine tumor, sir, it is cell of origin. Actually, sir, usually it differs. Exactly,
So you should read
How does
about
the behavior treatment clinico-pathologically vary? Cell of
yes, sir.
poison, leave that thing. Yeah.
Yes.
So you should read about what is carcinoid, what is an atypical carcinoid, what is large cell neuroendocrine carcinoma, and what is small cell lung cancer. These four histopathological differences you should know.
Yes.
Okay. So what is neuroendocrine typical carcinoid? What is how is an atypical carcinoid? And what is large cell neuroendocrine carcinoma? And how it is different from small cell lung cancer.
So that way you must be knowing based on Ki-67 value. How do you differentiate
Yes,
between
sir.
grade 1,
Mitotic
grade 2?
index is high when it comes to small cell. The mitotic index and the Ka67 will be actually slightly low. In
You have to be specific. There are cutoff values which you need to remember. So go and read those things. That up to 2% is grade 1, up to 10% grade 2, and more than 10% grade 3 in lung. And it's different in a pancreas PNET, and for lung neuroendocrine, the cutoff values are different. For pancreas, it is up to 20 and it is 10. So you need to read that values for Ki-67 is different for lung as well as for pancreatic and interstitial neuroendocrine tumors. To different grade 1 and grade 2.
Yes.
So how do you stage small cell carcinomas of lung for treatment purposes?
Sir, it is based on the VAL-ST staging. We group it as a limited stage and extensive stage. If we can enclose the tumor within one radiation field, single radiation field, so it is a limited stage. Otherwise, it is extensive stage.
Okay. By chance, if it would have came out to be a squamous cell carcinoma, how would you have worked the patient differently?
If it is, sir, first of all, IHC, we will do P40,
It
P63.
has come out to be squamous cell carcinoma rather than small cell. The biopsy showed squamous cell carcinoma.
We will prefer like NGS testing, molecular analysis.
For a T4N2 tumor, you will directly go for molecular analysis. What workup you want to do further? Your staging is confirmed for T4N2 with PET scan, or you do want to do anything else for staging?
Mediastinal stage.
So whether it's required or not, and will you do it in this patient, midastern staging, if it was squamous?
Sir, if it was squamous, yes, sir, I would prefer a mediastinal staging to be done.
How will it help in your management?
Sir, I would like to discuss this case with the surgeon. So, single station or multi-station actually.
PET is in front of you, no? You have taken. So in bronchoscopy, where you want to take biopsies from these nodes in the mediastinum to prove the staging or no?
Yes, sir. You should.
So you said it's already multi-station N2 based on your PET scan.
Multi-station.
Yeah. So whether it will come for surgery or not?
So this patient is having an encasing right lower lobe, is encasing the right pulmonary artery also.
Yes,
So
sir.
Still you want to consider resection in this patient?
No, sir, resection, no, sir. Like, we'll go for chemotherapy only, sir. If it is squamous.
So that's what I'm saying. If you're planning chemo RT, so will doing a mediastinal staging help you in this stage, or can you avoid that thing?
You can avoid, sir.
So if a Hyler node was positive, what are the chances of opposite Hyler node positive? You will not include it in the radiation field. So what are the chances that PET will miss and you will find a opposite Hyler node in a mediastinum staging?
Sir, I cannot understand.
So is there a chance that you will find a left Hyler node when you do a mediastinum staging which is not seen on PET, which will change your radiation field?
No, sir, unlikely. In
So
this
why do
case,
we do midsection staging then?
sir, in this case, there is actually multi-station, so surgery is not feasible, so I'll not prefer a mediastinal stage.
So not to decide your radiation field, you think it will not, no chances that a left hilar could be positive based on these findings.
It will highly possible that it is positive only, sir.
Left hilar, left hilar. So how will you demarcate your radiation field?
Uh, left hilar, sir, PET is actually not showing any uptake in the left side, so chances are very less.
So what's the percentage key when you do midsection staging rather than PET? How much upstaging a midsection staging does, or how does downstaging it will do? What are the percentages?
Sir, around 5 to 10%.
So then you will miss 5 to 10% based, and then your radiation field will miss that node, and then you will have a marginal recurrence. So it's always better to discuss and go ahead with this staging because your radiation field will vary. If that left hilar lymph node, the field will become big, and then they will need to see where at that. So it's always better even when you're going for CTRT to do a midsection staging, but that will confirm your field of radiation.
Sriram, which all patients will you send in NGS and lung cancer?
Sir, usually adenocarcinoma, the stage 4 disease.
Only stage 4 disease.
Sir, in adjuvant in the post-op setting also, sir. No, sir, all patients
So
with adenocarcinoma.
for all patients, you send molecular test for lung cancer.
If it is
All
adenocarcinoma,
adenocarcinoma. Suppose stage 1 A patients, will you send a molecular test? What is the significance?
sir, because
Stage 1 A
this,
patient.
if we are planning to give means adjuvant osimertinib, then
For stage 1 A
What's the
patient.
inclusion criteria? That is what he's asking. Sir, what stages
stage,
are included in that
sir,
trial?
stage 1B onwards.
Yeah. Okay.
Usually for
Send it up to stage 1B onwards, not stage 1. Okay. So in this patient, you are planning, suppose if it is common cell carcinoma, you are planning chemoradiation in this patient.
yes, sir.
Right. So
how will you work up for fitness of this patient for chemoradiation?
Sir, first of all, I would like to get because he is having underlying history of cardiac disease also. If chemoradiation is given, first of all, I would like to get a means full cardiac evaluation. I would also like.
What do you mean by full cardiac examination?
Sir,
You
2D
need to be more
echo.
specific here. Yeah.
No, sir. 2D echo to be
Okay.
done.
Okay.
And I'll also look for because he's 68 years. I would like to do a means audiometric examination also to document the baseline if sensory neural loss is there or not, like to document.
More important than that, will you like to do PFT DLCO?
PFT also. Yes, sir.
PFT, only PFT or PFT DLCO?
PFT, DLCO, both, sir.
So how will it help? So what is the
Sir,
cutoff you will take for PFT DLCO
sir,
to give CTRT?
at least 40%.
Okay.
Because sir, radiation-induced pneumonitis can cause further restriction. So I would like to baseline documentation.
Okay. And in scammers, do you want to get some molecular testing in this patient? If it would have been scammers?
Sir, the chances of getting a targetable mutation is only around 5 to 10%. So less than 5%.
Scammers 5 to 10%.
No, sir,
What
less than
data you are
5%.
quoting here?
Less than 5%. So
No,
I
less
will.
than 5 is also a big number for scammers. So
Sir,
it's around 1% only. EGFR is 1 to 2% that is found in Indian studies. In TMS series, so 1 to 2%. From the PGI series, they didn't find much of a difference. They said कि it's mostly adenoscammers where you find, but still most guidelines say कि even if 1% is there, there might be benefit of anti-EGFR therapy, and you do it in this. And in adenocarcinoma, what all markers you will want to test in molecular? You will send a comprehensive or you will send a limited one? What all markers you will want to test?
Sir, at baseline, EGFR, ALK, and ROS.
So will you give any adjuvant treatment based on ROS? If it is ROS positive post CTRT?
No, sir.
So why do you want to do that?
No need. Only EGFR and ALK.
Okay, for ALK you will give some adjuvant treatment?
Sir, if it is ALK positive, you can give alectinib 600 mg.
Okay, post CTRT?
Post CTR.
Sir, no, sir. Post CTRT,
So post CTRT, there no data.
no data.
Okay, okay.
What EGFR post CTRT?
Sir, suppose if it is EGFR positive, then you'll give osimertinib 80 mg OD for 3 years. That is based on the LAURA trial. Sorry, not 3 years, sir, and indefinite period till progression. Based on
Suppose you have a patient with the EGFR is positive and PDL1 is positive after chemoradiation.
yes, sir.
How to treat? EGFR is also positive, PDL1 is also positive.
Sir, more likely that EGFR is the driver mutation. So we'll prefer EGFR first. So osimertinib can be
Does immunotherapy work in patients who are EGFR positive?
usually no, sir.
Not usually, it doesn't work.
Doesn't work.
That's the reason. The conventional teaching is that it doesn't work. Okay. So if it would have been a PDL1 positive and irrespective of PDL1, if it is EGFR negative, will you look for PDL1 for giving post CTRT immunotherapy or you will give in all patients?
Sir, we'll give in all patients. We'll look for only the response of the patient post CTRT.
And how much days post CTRT you will start the patient on immunotherapy drug and what immunotherapy drug will you use?
So usually 42 days. Usually durvalumab based on the Pacific trial.
So that's the only data. Yes, durvalumab is the only one which will give. And how many patients in the trial completed 1 year of durvalumab? And what are the problems which they face, which were the most common cause of discontinuing?
Sir, ILD mainly.
Lung toxicity. Yeah, post CTRT, there are a lot of lung toxicity which led to discontinuation. So you need to be careful while giving. Uh, so so if the patient was diagnosed outside and was given some NACT with some chemotherapy, how will it affect your CTRT? How will the patient's toxicity differ if a patient has come with some cyclopaclitaxel carbo and then came to you and you planned CTRT?
Uh, Basically, sir, hematological. To start the treatment sometimes may be difficult.
So they are seeing that there are more toxicities or lung toxicities where the patient has been given more cycles of chemotherapy pre-CTRT. So we need to be careful with that thing. What type of chemotherapy will you give along with radiation therapy? What are the options in squamous and in adeno?
Sir, can give paclitaxel and carboplatin.
Give
Or
the schedule, dosing, and
yes, sir.
number of cycles.
Sir, yes, sir. Paclitaxel 50 mg per meter squared weekly and carboplatin AUC2, that is one option,
It is
sir.
50 or 45? What trial you are quoting for 50?
45, 45 mg per meter.
Okay, okay.
And
For how many cycles?
sir, so four cycles.
Are you sure? So you give radiation for how many weeks? What is the fraction of radiation you give in radical CTRT?
Sir, usually 60 gray, 30 fraction. So sorry,
So
sir.
30 fraction is how many weeks?
Yes, sir. So 5 to 6 weeks.
No, so you will stop paclitaxel carbo at 4 weeks.
No, sir. No, sir. I give for 6 weeks.
And after 6 weeks, will you continue paclitaxel carbo for some more time or you will stop at 6 weeks?
Actually, sir, one
What
continues.
what did data, what did trial says ki after paclitaxel carbo 6 weeks, do you need to give some more of paclitaxel carbo or you stop at 6 weeks?
Can continue, sir.
You can or you need to?
We need to continue, sir.
For how many cycles?
One.
So it says 2 cycles,
Two
3
cycles.
weekly. That is what given 200 milligram per square Paclitaxel and AUC 6 of carbo. But we need to look at toxicities. What other regime you can give apart from Paclitaxel carbo?
So you can give paclitaxel and cisplatin also. It's also
Okay.
one.
Okay. Other?
And other options can be, sir, can give an etoposide also they have tried, sir.
More effective than that in squamous
Sir,
cell carcinoma.
more efficacious. Gemcitabine, carboplatin.
So there's some data for vinorelbine also.
Vinorelbine also was tried, sir. But the means most efficacious of the lot was paclitaxel and carboplatin.
Are you sure? What was the 3-year OS in that? What was the endpoint of that trial? Was it more efficient or it is non-inferior and less toxicities?
Uh, non-inferior and less toxic.
Yeah. So the PFS is higher with vinorelbine, but the toxicities are much more. So it is non-inferior. So Paclitaxel carbo is preferred in elderly patient, but Gem carbo, Gemcis and vinorelbine cis remains valid option in terms of efficacy. And do you continue vinorelbine cis or Gemcis post CTRT also?
Post CTRT, sir, 3 weekly regimen you can
So we don't
continue.
continue. Yeah. We don't continue. As per trial, we stop it there. Okay.
Srita, what is Pacific 2 trial in CTRT?
Sir, that is patients who have had means post CTRT in locally advanced CA lung. We give durvalumab, sir, post RT.
I'm asking Pacific 2 trial.
That is Pacific, no? Pacific 2, Dr. Anup is asking.
I'm asking Pacific 2 trial. So you're giving CTRT in this patient and planning for adjuvant.
Concurrently, we are giving durvalumab along with RT.
Yeah, that is Pacific trial. What was the results of Pacific 2 trial?
Sir,
Beneficial in patients?
Sir, I have read only the Pacific one. I heard of the Pacific too, but exactly don't.
So you are clinically using Pacific, so Pacific 2 might be beneficial or not. You can use your
Yes, sir.
So the approach of giving neoadjuvant immunotherapy as well as concurrent immunotherapy along with radiation has failed. So we hope that neoadjuvant will work. We are now moving in surgery. We are moving to a neoadjuvant immunochemotherapy. But the approach of giving neoadjuvant immunotherapy neoadjuvantly and concurrently has not shown benefit, and it's the adjuvant immuno which has shown benefit in post-CTRT phase, where it is opposite in when we do it in a neo pre-surgery setting. Then both has evidence here.
Sriram, suppose this patient had a T3N2 disease, non-small cell lung cancer.
Yes, sir.
Will you defer any treatment or difference of treatment?
Sir, I will look at whether it is single station N2 or multi-station N2. I will discuss with the surgeon.
Okay.
So if it is single station, then we can offer surgery as an option.
So single station 5 centimeter versus single station 2 centimeters. Will it make a difference?
Sir, more than 2.5 centimeter is according to the thoracic surgeon's guidelines, it is considered as bulky.
More than 3 centimeters. The last year's WSCLC guidelines, more than 3 centimeter we take as bulky.
Yes.
Okay.
It's non-bulky, we can offer surgery also as an option. So
you definitely you will go for straightly. You go for surgery.
No, sir. Now we have recent data to support means neoadjuvant chemo plus immunotherapy. So I will prefer if cost is not an issue, and so I will go for neoadjuvant chemo plus immunotherapy. Then I will offer surgery.
What the regime you will use for neoadjuvant chemo immuno?
Sir, as of now, neoadjuvant the Checkmate 816 trial, that is nivolumab 360 mg for 3 cycles along with the platinum doublet.
Does it show OS benefit? There is one trial which showed OS benefit. Checkmate 816 didn't show.
Sir, recently a small OS benefit last week it showed, and only trial so far established or overall benefit is a perioperative setting is pembrolizumab.
Yeah.
Keynote 671.
So how will you choose your patients for keynote versus checkmate? Will you
Sir,
prefer?
first of all, sir, dose of nivolumab is 360 mg. Basically, sir, if cost is a constraint, patient then only in neoadjuvant setting we have only a means 3 cycles of immunotherapy. So in that setting, we'll prefer checkmate 816. And also, sir, if it is like checkmate 816, 1B stage was also included in the inclusion criteria. But whereas in checkmate 6-7, stage 2 and 3B were only included. So that is one factor. And patient, if he's having cost is not a constraint, then I will prefer checkmate 671. Because
So will you continue nivolumab post-surgery in all the patients in checkmate 816?
What is checkmate 671? Can you repeat?
Sir, pembrolizumab along with the platinum doublet chemo, that is
Yeah,
It will be
perioperative.
keynote.
Sir.
You're
Keynote,
confusing.
not
It is
checkmate.
keynote 671.
Sorry, sir. Keynote 671.
Yeah,
Sorry,
yeah.
sir. Keynote 671.
So what happened in checkmate 816? How many percentage? What was the endpoint of checkmate 816? Primary endpoint?
Sir, PAT-CR was seen. That was
How
around
much? How much was the difference between
For
control and
25%, sir, almost PAT-CR.
PCR?
And there was EFS benefit, sir.
okay? And what was the interpretation? If there was a PCR, whether can you omit adjuvant nivolumab?
Sir, as such, sir, since perioperative setting only offered OS benefit in the keynote 671. So
In checkmate 816, you have used 3 cycles of chemo and then surgery done. One
Sriram?
patient has complete pathological response and second patient doesn't have CPR. Will your management differ post-surgery?
sir, as
Sriram.
per the trial, no.
Sriram, checkmate 816 is basically neoadjuvant regimen.
Only
Okay.
neoadjuvant.
Neoadjuvant. And it is checkmate 770 trial, which showed
770.
preoperative nivolumab, which showed an improvement in the overall survival. Okay. That
Yes.
was also presented in 2024 ASCO. Okay. Then keynote 671 trial, which showed an improvement in the overall survival.
OS.
That is the first trial to
show overall survival
benefit. Okay. Then other trial is an agent trial.
Sir, one agent trial, durvalumab.
Yeah,
But
that's
as
also
such,
shown an
sir,
improvement. Yeah.
yes, sir.
So all the trials, agent trial, checkmate 816, keynote 671, and the durvalumab trial, then checkmate 770 trial. All the trials showed an improvement in the overall survival. The perioperative immunotherapy trials. Okay.
So Ravi, the only setting, so you are saying of financial constraint, the only setting we can take from checkmate 816 is some patient who is not affordable and who had a CPR. That is some patient who you can, in that setting, in financial setting, can leave post-operative immuno because those patients are doing good even without post-operative immuno if there is a financial constraint. Otherwise, you will continue a perioperative approach, which has shown to be, as they know head-to-head trial, but seems to be a better approach going forward.
Yeah, but Sriram, what is NeoTorch trial? NeoTorch trial in perioperative setting.
Sir, is it P-Nevo? Sir, I read about it exactly. I'm not able to recall, sir.
Chinese molecule which has come to toripalimab.
Sir, toripalimab.
Yeah. So that showed an improvement improvement in the PFS. Okay. And the PCR are shown a better benefit similar to the other perioperative immunotherapy trials also. The cost is around 5 lakhs for perioperative immunotherapy. But if you go for a checkmate 816, it costs around 12 lakhs rupees.
Yes.
In the four cycles, 3 to 4 cycles.
So
Okay.
there are multiple options which are coming. And there are no head-to-head comparisons. So based on multiple factors, the cost, the tolerability and availability, we need to make a choice